At the moment, obviously in the midst of an opioid epidemic, not only in Canada, but seemingly obviously in the US, the UK, it seems all over. Can you share some statistics with folks to get some comprehension over the scale of this issue?
Yeah, where do we start? If we look at Canada, 2016 had about 2,800 confirmed deaths from opioids, and for 2017 we don't have the final numbers yet, but we're expecting that perhaps to surpass 4,000 people. We have more people dying from opioid-related harms now than we ever did at the height of the HIV/AIDS crisis in the mid 1990s. And that was, and I say at the height of the HIV/AIDS crisis, we don't seem to be anywhere near the height of the opioid crisis. The harms
Wow.
seem to be accelerating. I think a very scary number comes from the United States, where it's estimated that over the next decade or so, about 500,000 people will die from opioid-related causes, and that's just a staggering number.
Yeah, it's mind-boggling, especially reading some of these stories about different communities in the U.S. and just the ravaging effects that this can have.
Well, yeah, exactly. I mean, you think about that when we're talking about death. That's if you think of the harms from opioids, deaths are at the top of the pyramid, and for every death, there's so many other impacts. People who have overdosed, people whose lives have been affected by addiction. So that there are many more harms besides just the deaths. I mean, the deaths are of course the most concerning, but the scale is much beyond that.
And for folks listening in, Doc, if trainers, nutritionists, practitioners who aren't as familiar with the opioid class or even why opioids are so addictive, can you give us a little bit of background there?
Sure. So opioids are a class of chemicals that have either are derived from the opium poppy and ultimately from opium, or are structurally similar to the substances found in opium, or have a similar kind of effect on the body. So common opioids that are used in clinical practice include morphine, codeine, hydromorphone, oxycodone, and fentanyl. And for opioid use disorder, for example, we find things like buprenorphine and methadone that are in common use. And of course, we see heroin or diacetylmorphine, which is another kind of opioid that's at this point has a very limited therapeutic use, is primarily used recreationally.
And in terms of the effect on the brain and triggering some of the reward centers of the brain, how are the opioid class of drugs influencing behavior in that sense?
Well, so there's two parts to think about. First of all, these opioids have analgesic or pain relieving effects, and in a world full of injuries and pain, that's a pretty powerful thing to be able to do. And opioids in many ways have changed. I mean, they've been with us with human culture for thousands and thousands of years, used to treat pain, dysentery, a whole variety of conditions in various forms. So in terms of the pain relieving effects, there are specific what are known as opioid receptors in the body, both centrally, so in the brain, as well as peripherally. In the receptor part of the nervous system. And so that's how the analgesic effect is mediated. When we're talking about the development of, so one important phenomenon is tolerance, that when somebody's exposed to opioids, you either need increasing over a long term, you either need increasing doses of opioids to have the same kind of pain relieving effect, or if you stay on the same dose, it'd have less and less of a pain relieving effect. That's the phenomenon of tolerance, and is mostly because you get upregulation, as far as we understand, upregulation of the opioid receptors. So you just don't get as much activation from the same kind of dose, and so that's why we often see people. That's part of the beginning of developing a dependence. And dependence is really distinct from addiction. Dependence just means that your body is essentially used to having a certain chemical around, and if that's withdrawn, you can get withdrawal symptoms, which is common with opioids, but other therapeutic agents. Addiction is a different kind of story. Addiction is essentially when we continue to use a substance despite it having harmful consequences in our life. And that happens relatively commonly with chronic exposure to opioids. There are discussions about how commonly, but part of what drove the opioid crisis initially was this false idea that with our new kinds of opioids, as represented by OxyContin, that there were very low addiction risks, even though we had plenty of evidence that that was not the case.
Yeah, I mean, it's amazing to think that a lot of these chronic pain conditions, whether it's bad backs, arthritis, car accidents, that the prescriptions for the opioid medications are, in fact, sort of driving this, in the sense that, as you mentioned, the idea, the notion that they were going to be so addictive was either underreported or underestimated. Is that correct?
Purposely so. The big so. My understanding, my interpretation of this history is that there was a template for success for the expansion of opioids that was built primarily in the area of palliative care. That there was this group of people, particularly towards the end of life, that had significant pain needs. And there was a group of physicians or healthcare providers who successfully used opioids to help ease the suffering and the pain, particularly the pain towards the end of life. And there were both some well-meaning clinicians and academics, together with profit-oriented pharmaceutical companies, which saw that as a good template for treating what was considered an epidemic of chronic non-cancer pain. So people who had chronic pain but were not dying from an untreatable disease that had a foreseeable future of 20, 30, 40, 50 years of life, but had significant debilitating pain. And the idea was that we should, it's our moral obligation as healthcare providers whose job is to relieve suffering, to make use of these supposedly effective therapies of opioids to treat chronic non-cancer pain. And that in many people's eyes is, including mine, was the genesis of our current opioid crisis.
Yeah, it was startling to me in a recent article that you wrote for the Toronto Star, how unlike other drugs and medicine that are subject to really high levels of scientific scrutiny, I think most people will be really surprised to find out there's not a lot of really good evidence in terms of long-term, randomized control trials demonstrating the effectiveness of opioids, which is, a little bit scary. Can you unpack that a little bit more for listeners?
Yeah, so we like to believe that we live in or operate in a science-based paradigm for healthcare delivery that uses high-quality evidence to make decisions about care. And in some areas, that is true. For chronic pain and opioids, that is really not the case. So there are zero long-term studies, and by long-term, I can say a year or more, high-quality studies demonstrating the effectiveness of opioids for chronic non-cancer pain. And further to that, I think now about a month ago, a trial was published looking at opioids versus non-opioids, so strictly pharmacotherapy for various kinds of arthritis. And the expectation was that, they took patients and they split them up into two different groups. One group would get, typical opioid therapy, starting from a weak opioid like codeine or tramadol, and then as their pain needs, if their pain needs were not met, then they would be stepped up to stronger opioids like morphine or hydromorphone or oxycodone. The other arm of the trial offered pharmacotherapy, but in a stepwise fashion, but did not include opioids. And the expectation was, the hypothesis of the investigators was that the opioids would provide better relief. The people who got opioids would have lower pain ratings, but that they would have more adverse effects. But amazingly, and this is really important, what they found was that the opioid group had more side effects, but the non-opioid group had better pain outcomes. And so we actually have good evidence now for osteoarthritis, at least, that we should prefer against opioids.